This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're with us today. And we wanted to do an in-depth look today as far as healthcare as a career. We're delighted that we have with us today Sharn Barbarin, who is the Chief Executive Officer at Medical City Arlington. Her nickname is Sharn, so with her permission, Sharn, welcome to the show.
Thank you so much, Steve and Thomas, for having me. Truly honored.
Can you tell us how you began your career in healthcare?
Yes, absolutely. I actually started my career in healthcare with HCA 25 years ago, and I have to say that I really am a testament to an investment in leadership. So I received my Master's of Healthcare Administration from Tulane University in New Orleans, Louisiana, and that's a component of a scholarship that I received. I was granted a postgraduate residency at Medical City Healthcare. And so immediately upon graduating with my master's degree, was able to position myself at a Medical City hospital, Medical City Las Colinas to be exact, for a year of residency. Then from there, promoted into several leadership positions, including director, on into Chief Operating Officer of Medical City McKinney. Then was at Medical City Arlington as COO, transitioned to Medical City Louisville as CEO, and now am proud to be back at Medical City Arlington, now serving as Chief Executive Officer.
That is fantastic. You know, what really motivated you, though, to pursue healthcare?
You know, like many, I had family members in healthcare, transporters, unit secretaries, ER clerks, even physicians. But I have to say that being at the bedside of my family while they were patients and witnessing the impact of the entire care team, that just immediately connected me to my passion to serve.
So that brings us a little bit to today. How do you, running a hospital, balancing the needs of the patient, the staff, and the families, give us a little insight into Sharn's job every day?
Wow. Well, I have to say that I'm truly humbled and honored because as CEO, I have that opportunity and really have blessed with the opportunity to oversee the strategic side of the hospital, quality, financial responsibility for Medical City Arlington, which is 433 beds. Now, with that hospital, we are caring for the sickest of the sick in many instances as a level 2 trauma center, comprehensive stroke center, and having a dedicated women's hospital that also specializes in neonatal intensive care is a large responsibility, but I'm blessed because I'm surrounded by exceptional physicians, exceptional care team members. And so for me, I have to tell you that the best part of my job really is just investing in my teams, driving a culture of employee engagement that then really positions us to be able to deliver on that quality, deliver on exceptional quality, expand our service line so we can continue to meet the needs of the community.
You know, as you look back on your career and you have listeners that maybe are seriously considering healthcare, what would be your advice to them as to the initial skills they really need to focus on?
Wow. Well, I will say that healthcare is the business of service. It's the business of people. So know your passion, embrace your authenticity, be very clear on what your career goals are, make those known to mentors around, seek out mentors, and then lean into every opportunity to get some exposure to healthcare setting, to expand your scope and your depth and breadth of knowledge so that you can then have a career goal with some defined endpoints.
You know, you talked a lot about how you give back and how you're a servant leader. But as you look back over your career, what are some of the greatest memories of satisfaction that you can remember?
Two things come to mind. The first is because of the role mentors played in my life, just witnessing the professional advancement of others is always satisfying. Seeing individuals come in and perhaps they're in food nutritional services and they let me know that they want to go and become a nurse, and we immediately get them ingratiated into a nursing program and then see them out and about caring for patients independently on a unit, those things bring me satisfaction, and I can name countless examples of that. But I have to say that the greatest reward in my career was standing beside my team and leading my team throughout the pandemic. We all were challenged in many different ways throughout the pandemic, but Medical City Healthcare cared for 12,100 COVID patients in that time period. And just witnessing my own team, the heroism, their selflessness, and the compassion, that just inspired me each and every day. Having the impact of the lives that we cared for, saved, and even the impact of families who I had the opportunity to hug as they suffered loss, that will stay with me forever.
Those are some very touching moments, especially during the pandemic. You know, Sharn, to our listeners out there that may be considering healthcare as a career, they probably always think of the clinical side of the equation, which obviously is extremely important in healthcare. But can you elaborate a little bit on career opportunities that may not be clinical, but are an integral part of supporting healthcare?
Absolutely. I'm glad that you bring that up because I think that most underestimate the myriad of options within healthcare. Naturally, you go to nursing, physicians, therapists, but I encourage everyone to look at the full scope. Administration is certainly one of those aspects. Going into finance, actually looking at even the world of dietitians, social workers, billing, coding, even being in research, biomedical devices, being in strategy, service line development, service line leads. Those are all huge components that play a significant part and contribute to every hospital's ability to be able to care for our patients.
You know, for people that maybe are thinking about healthcare as a career, what do you think one of the biggest misconceptions exist related to healthcare?
I think the biggest misconception is that it is only clinical and that perhaps you need to have an affinity for being at the bedside. But the role of healthcare is so much deeper than that. There's research, there's biomedical devices, there are supply chain demands. Even just playing a part in general medical education is a huge component of the healthcare field. One thing that I think is consistent is that there actually needs to always be this need and this impetus to serve. So regardless of what aspect of healthcare you're in, I think that the one silver truth is that there is a connection and a calling to serve.
You know, you've answered all my questions and done a great job, but the listeners out there, what is your final parting thought to them about why they should pursue a career in healthcare?
Healthcare is, I would say, one of the greatest opportunities to give back and be a part of something larger than yourself. And I go back to it being a calling, but it also is a passion. And I feel that it is its own master class in people, empathy, relationships, and it allows you to really play a significant role in advancing the care and improvement of human life. And so for me, it has not only been a career, but it's been a gift and a blessing.
This is one of the dynamic healthcare leaders in the Metroplex. She goes by Sharn Barbarin, the CEO at Medical City Arlington. Back with us again in the next segment. Stay with us on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're going to continue hearing the story of the career of Sharn Barbarin, who is the CEO at Medical City Arlington. Something happened early in her career that triggered this meteoric rise. I am really intrigued by how you went from residency to McKinney to Arlington to Louisville to Arlington. Wow. I mean, that was a fast track. But I'm curious, as you go back in that timeline, it seems like for you, getting that residency while you were still working on your master's was like your first big break. But I'm wondering, what was your first real thrust to be able to move up so dramatically? I mean, you were COO, just boom, boom, boom.
You know, I have to say that early in my career, I was fortunate to be surrounded by mentors that took a vested interest in my advancement. So with that residency, you're right, it allowed me to have not just an opportunity to be in healthcare, but at the time, Medical City Las Colinas was just being built. So I had the opportunity to be a part of a greenfield hospital that gave me great immersion into every aspect of healthcare. And with that, it allowed me to, one, because of the support of the CEO there, continue to advance and get exposure to additional service lines that I wouldn't have otherwise gotten exposure to. For that reason, he then was able to confidently provide his vote of confidence when there was a COO opportunity at the McKinney Hospital. So I'm truly thankful for that. Once I got to Medical City McKinney, again, another great opportunity for full immersion. The CEO there gave me non-traditional CEO roles and responsibilities. Outside of ancillary and support departments, I was given quality, human resources, infection control. I embraced every component of that. And so I always encourage everyone, where there's an opportunity, you step up to the challenge and say yes, because you only are increasing your scope and you're increasing your depth of knowledge.
Just listening to you, you are obviously exceptional. And that's
Thank you.
I mean, that's part of the reason why you are where you are. There's no question about that. But how do you approach every day from that exceptional perspective? And let me ask it in this context. Patients that are upset, doctors that are upset, insurance, billing issues, blah, blah, blah. I mean, all the stuff that can be a daily beating in healthcare management. How do you stay above it so incredibly well?
I think it's important to know that at the heart, everyone wants to be heard, validated, and empathized with. And so I approach every conversation as a meaningful conversation to invest in listening versus being heard. And that allows me to be able to hopefully find the win-win.
Let's think about some parents out there who might be listening who have teenagers who are thinking about going into this. How would you advise them to be as exceptional as you are?
Oh, gosh. You know, first I have to give credit to my parents for their role and investment in me. So as a parent of my own teenagers, I'm hoping that I am modeling what my parents did for me, which was, one, making sure that I instilled in them the idea that everything was possible. Anything was possible if you worked really hard. And that if you invest in your greatest talents, that will be the most rewarding for you. I also always prioritized, and my family did this for me, they prioritized excellence in academics. And for me, that has translated into me wanting to display academically and excellence in quality. It now is translated to me wanting to demonstrate excellence in our service outcomes. And so laying that foundation of having high expectations of yourself so that you can continue to be better for others, I think is foundational.
I'd love to ask you just a couple of outside the hospital, outside the office questions, because whenever you have the chance to talk to somebody who is obviously exceptional in this day and age, that's getting more and more rare. What kinds of things do you do in, say, personal development to keep your edge, to grow your edge, to reevaluate your edge? Outside of the hospital, what do you do to be so good?
I invest in a lot of reading, a lot of podcasts. I certainly stay engaged with American College of Healthcare executives, even within our chapter, just making certain that I am always studying and investing in my learning. My mother was a teacher, and her guidance always was that regardless of what's going on, the expectation is that you're learning something, that you're growing, you're investing in your advancement. And so I continue to approach my professional career in that same way.
And then what about personal exercise, things to keep your mind sharp, your body sharp? What do you do there?
Yes. For me, I would love to say that I'm this avid exerciser. So that's a failure in my category. But I will say that I take great time to just make sure that I have moments of silence, that I am purposeful and present and filling my cup. And for me, filling my cup is spending every amount of time possible with my sons, as much as possible, and with my husband. The other for me is making sure that I'm having those moments of meditation so that I am centered and having an opportunity to clear my head. And the evenings is my most productive time because I'm able to kind of sort through the day and plot out the tactics that need to be achieved the following day.
That's just awesome. It shows. I'll tell you what, it really reflects. Let me ask you this. Not every job is good for everybody. So what are the benefits of going into healthcare? Why should somebody go into healthcare? And then why should somebody not? Or would they consider maybe this isn't for me?
Wow. I think that it's really astute to recognize that everything isn't for everyone. And so I think that starts first with the candidate, right? Them knowing their own authenticity, knowing what actually fills their cup, knowing their own passion. There has to be some truth there. You cannot follow a career path because a friend is doing it. It's not going to be enough to sustain you. Healthcare is one that requires not just the intellect, but more than that, it requires a tremendous amount of emotional investment. There's an emotional bank that goes into healthcare. And so I think being really honest with yourself about whether or not you have that bank to be able to pay forward to others will be important because it requires resilience. It requires a certain level of grit to be able to sustain the interactions, to be able to sustain perhaps some of the tough moments that patients experience, to be able to even sustain some of the deaths that occur with any healthcare setting. With that said, any individual that is willing and ready to have an impact on a family, that's the baseline criteria for wanting to be in healthcare. Making a difference, wanting to be a part of something bigger than yourself. If you have that within you, it's worth you exploring a career in healthcare.
Yeah, I love you said emotional bank, because some days you're getting people that they're not on their best.
That's right. That's right. Every day you're interacting with the individual in high moments, certainly the birth of a child, the recovery from a surgery. But there are other times when you're dealing with not just death, but you're dealing with less than ideal family circumstances. And you're having to walk through the social aspects with a family. And that does require you being able to have that bank to be able to tap into, and then recognizing if you have the skills and the support system to be able to pour back into your bank as you're always giving it.
Sharn, your hospital is right in the middle of the Metroplex. I mean, anybody could get to you from any other part of the Metroplex in about the same amount of time. What is the dynamic? Tell us about your hospital in Arlington.
Well, we are a 433-bed, level 2 trauma center, comprehensive stroke center. We have a dedicated women's hospital that specializes in level 3 maternal care, level 3 neonatal intensive care. We like to say that we provide service of all service lines with the exception of burn and transplant. And so we can serve all. And I think what's great about that is that when you look at just the city of Arlington alone, not only is it an economic growth engine in terms of its population growth, but it has soon become a sports destination with certainly the Rangers, the Cowboys here. As we've continued to add additional stadiums, it's bringing in new venues, world-class resorts, the World Cup coming. All of those things put a burden and a responsibility on our hospital to make certain that we stand ready to be able to service the needs of not just our growing community, but be able to position ourselves as that highest level of care should it be needed for some of these world-class events.
Absolutely. And, you know, when you're thinking about where am I going to establish my medical care, having that comprehensive basket of services is certainly important.
Absolutely, because you're not only just caring for the patient, you're caring for the entire family. So being able to have as many services within one location allows for that patient's support system to still be readily accessible to them.
Sharn, you've given us a great tour here, not only of HCA and Medical City Arlington, but also a wonderful career. Congratulations.
Thank you so much for this opportunity.
Sharn Barbarin, the CEO at Medical City Arlington, thank you for your story. Next, a revolutionary new prostate cancer treatment developed right here in the Metroplex. We'll tell you about it when we come back.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. And we want to talk to you not only about prostate and prostate cancer, but some of the treatment using ultrasound. And we're delighted that we've got with us Dr. Daniel Costa, who's an associate professor of radiology at UT Southwestern. Dr. Costa, welcome to the show.
Thank you, Steve. Great pleasure to be here.
You know, I know our listeners have heard about prostate cancer, and men should routinely have their PSA checked after a certain age. But just from your perspective, before we even begin this detailed discussion, why should men worry about or care about prostate cancer?
Well, Steve, other than skin cancer, prostate cancer is the most common cancer in men in the United States. Just to give you an idea, according to the American Cancer Society, it's expected that 1 in every 8 men will be diagnosed with prostate cancer during his life. Now, being that common, one might ask why we don't hear as much about it. Right? One of the interesting things about prostate cancer is that some forms of the disease are not very aggressive and can be watched safely. However, that is certainly not always true, to a point where around 35,000 men die of prostate cancer every year in this country. Just to put this in perspective, around 43,000 women die annually of breast cancer, and not that different figure. It is, therefore, very, very important that we fight this misconception that prostate cancer is just part of normal aging and should be treated as a not important disease.
You know, you just cited a statistic. 1 in 8 men at some point in their life could be diagnosed with prostate cancer. That really is amazing. What is the best way to diagnose prostate cancer?
Yeah, so most men will be screened with a test called PSA. This tends to begin at age 55 unless it's a man who has risk factors such as family history of prostate cancer. The PSA is a blood test that measures the amount of a protein that is produced both by cancerous and non-cancerous cells in the prostate. After the PSA test is done, if it's higher than normal, a urologist will normally recommend a biopsy. And the biopsy is the way that a man finds out that he has prostate cancer. In the biopsy, a physician uses an ultrasound machine to help collect some pieces of the prostate. And these fragments of the prostate will be assessed for the presence of cancer. Until about 10 years ago, these biopsies would be done in what we called random systematic sampling. So 10 to 12 pieces of the prostate would be taken evenly spaced throughout the prostate, hoping that if a cancer was present, that approach would catch it. More recently, fortunately, we are able to use MRI before the biopsy to identify the areas that are most suspicious, and those are the areas that we focus on during the biopsies, helping not miss important cancers.
Do you still use a scoring system? I know at one point there were Gleason scores that were used. Are they still used?
They're still used. There was a revision to the nomenclature. So now we, instead of calling Gleason score, we call grade group. The Gleason score is a number that goes from 6 to 10, 6 being the least aggressive, 10 being the most aggressive cancer. And there was a little bit of a confusion because a man with a Gleason 6 could see this as a 6 out of 10, but it's actually the lowest risk possible for a prostate cancer. Now, the grading system was revised so that now it is a 1 to 5, 1 being the least aggressive and 5 being the most aggressive cancer. And this is based on the characteristics that the pathologist will assess when he or she is reviewing those pieces of the prostate after a biopsy is done under a microscope. It is a very important part of the assessment of how aggressive that cancer is, which will then put the patient within certain risk categories that will help assess what is the best management strategy for that particular patient.
What age would you recommend screening PSA?
The recommendations from the societies that issued this guideline is to start at 55 after a discussion with your primary physician or urologist.
Is there any age, like if a man reaches age 80, there's no need to test for prostate cancer anymore?
There is, in general, rather than a set age, what we take into consideration is the life expectancy that patient has. So if a patient is expected to live 10 or 15 years or less than that, then it would not be reasonable to continue to do PSA screening of prostate cancer using PSA. If we just look at age, absolute number, it would be some societies will say 70, other societies will say 75 years old. This is highly dependent on what's the expected, how many years that patient is expected to live from that date on. Societies will say 70, other societies will say 75 years old. This is highly dependent on what's the expected, how many years that patient is expected to live from that date on. Societies will say 70, other societies will say 75 years old. This is highly dependent on what's the expected, how many years that patient is expected to live from that date on.
Thank you. You've done an excellent job of laying the foundation. Now we're really going to move into some exciting discussion. Let's assume a man is diagnosed, no question, prostate cancer, given a score. What are the treatment options available to that man?
Some men that have the less aggressive forms of the disease can be offered what we call active surveillance, which is a form of monitoring that cancer. This means that these men will normally undergo regular visits, checking their PSA, getting MRIs, and sometimes repeating biopsies. This is all done to make sure that that cancer is not getting worse. So that is option number one, active surveillance, usually reserved for men with low-risk forms of the cancer. Now, the other two conventional treatment options are surgery and radiation therapy. With surgery, the urologist removes the entire prostate. Now, because the nerves responsible for sexual function run very close to the prostate, and because the urethral sphincter, a sort of valve system that we have, these are very, very close to the prostate. Occasionally, they are damaged during the surgery. And when that happens, a man might struggle with erectile dysfunction or urinary leakage after the surgery. With radiation therapy, radiation oncologists will direct radiation mostly to the prostate in order to kill the cancer without removing the gland. So that's one of the differences compared to surgery. This is usually done over multiple sessions in the course of a few weeks. The main side effects come from the fact that for the radiation to reach the prostate, it has to cross other areas of the body, especially the bladder and the rectum, and that's where the side effects come from. Usually the patients will complain of having to use the bathroom more frequently, some pain during urination, and this can last some time. Another commonly mentioned downside of radiation is that in men where that treatment fails and a repeat treatment may be necessary years down the road, that patient may not have that many good options since repeating radiation tends to not be as effective. And surgery after radiation can be very, very challenging from a technical standpoint. Now, knowing these side effects does help us understand why patients sometimes struggle with the perception that the solution to the problem may bring consequences that are actually worse than the disease itself. And I can say that having met hundreds of such patients, I see that as a huge source of anxiety in their decision-making process.
You know, I had a friend of mine that had prostate cancer, opted for surgery. There was a recurrence, and they had to do radiation, and there was a recurrence again. And I think they actually used a form of hormonal treatment. Is that something that you can use, hormonal treatment?
Correct. Yes, that is a form of treatment. The fancy name is androgen deprivation therapy, so ADT. And that's usually reserved for either recurrent disease, as you mentioned, or patients who have very, very aggressive disease from the very beginning, and that disease has spread outside of the areas that would be treatable only with surgery or local radiation. So it's an adjunct to the other forms of treatment, or a third-line treatment option for the patients who have already failed surgery and radiation.
This brings me to the real innovative and exciting part of this interview. I know you're going to talk about TULSA, and I'm going to let you explain to the listeners what TULSA is, but how you use ultrasound to help treat prostate cancer. So what, to begin with, is TULSA?
So TULSA, Steve, stands for transurethral ultrasound ablation. That's a mouthful, but basically what this means is that we use the urethra as a natural opening in our body where we put a small probe, and that small probe contains very small ultrasound devices. These devices can be turned on and off selectively during the procedure to achieve high temperatures in very selected locations within the prostate. And it's this high temperature that will then destroy the tissue that we choose to destroy. It is a treatment that is safe. Patients have a very quick recovery with fewer side effects and comparable cancer control rates compared to the standard of care.
Once again, the Metroplex is on the cutting edge of healthcare technology and development. We're listening to Dr. Daniel Costa from UT Southwestern Medical Center. More on the technique he helped develop, TULSA, when the human side of healthcare returns.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
We love new medical technology stories at the human side of healthcare, and we have one that was co-developed right here in the Metroplex. We're talking with Dr. Daniel Costa, Associate Professor of Radiology at UT Southwestern, about this TULSA procedure for treatment of prostate cancer.
You know, you're being modest. It's my understanding that you and your team at UT Southwestern actually pioneered this procedure. Can you elaborate on that?
We're very fortunate to have participated in the research that led to the FDA approval of this device in late 2019. In 2020, following the FDA approval, we started offering this as a clinical service and have treated, as of the end of 2022, 110 men. It's been a great experience for the patients. We had no major complications. All men went home on the same day, and most recovered or are on their way to recover their baseline sexual and urinary function. We did have a few men who had small cancers detected on follow-up scans. Some were too small and a very low grade and could be safely monitored. Two required additional treatments. One chose surgery, and another one chose to repeat TULSA, both with very good results.
So I've got to ask you this, and I know you're not biased because you pioneered this treatment, but what in your mind as a physician are the advantages of TULSA over surgery or traditional radiation?
Oh, Steve, the TULSA procedure is done in an MRI scanner, and this is a very important feature because it gives us real-time images of what's happening during the procedure. It not only helps us plan the procedure, but it also helps us monitor that we are achieving what we want to achieve. Whenever that is not the case, we can make the necessary adjustments during the procedure to ensure that the cancer is properly destroyed and that we are keeping safe distance from the areas that we do not want to cause damage to. The idea of an image-guided focal treatment of prostate cancer is not new, but this ability to monitor the delivery of the treatment in real time is certainly the cornerstone of making TULSA a very robust approach to this. Some other advantages are that the patients are discharged the same day, And because of this precise depiction of the anatomy, the patients are less likely to experience the side effects of the traditional treatment options. When it comes to the cancer control rates, the results are very promising and I would say comparable to the standard of care. Now, it is important as a footnote there to state that by being a new technology, we lack long-term data. Right? So I cannot tell a patient that I'm seeing today how a patient that I treated 10 years ago is doing because we only started offering this 2 years ago. But we are certainly very committed to following these patients that we're treating, and so that we are able to report how they're doing 5, 10 years after the procedure. Another interesting finding that I should mention is that in men who had this procedure and who needed additional treatment, they remained good candidates for having surgery, radiation, or what is also very interesting, repeating TULSA as a salvage procedure.
You know, that's a really interesting point you made. And many of our listeners may not have heard what you said earlier. Many times if you have just the traditional radiation and you have a recurrence, surgery may not be a good option to do. By doing this procedure, it sounds like you really keep all your options on the table if there were a recurrence.
You are correct.
You know, if there are men listening and they suspect they could have prostate cancer and they maybe recently were diagnosed, would they know if TULSA would be a good option for them? What would be some of the criteria in your mind that you really would want to meet before this procedure was done?
That's a very important question, Steve. Although TULSA is an exciting and promising tool, it's certainly not a great fit for every patient. When we are evaluating a man, we need to make sure that several criteria are met. It's a list that includes making sure that that man can undergo an MRI under general anesthesia, that his cancer has not spread outside of the prostate, that the cancer is in a location within the prostate that is not likely to result in injury to those important structures that we want to spare, and that the man does not have the large deposits of calcium in the prostate that could interfere with the treatment. I cannot emphasize enough the importance of selecting the right candidates for this procedure. And that is one of the reasons why we've been successful at our institution. A place where I am very grateful to have a very strong collaboration with radiology, urology, oncology, and radiation oncology. I am a radiologist, and I'm the one here talking with you today, but I represent a large group of providers that work together assessing these men before, during, and after the procedure. And it would not be a successful program without that partnership.
I'm assuming even with this procedure done, you work closely with a urologist post-procedure. Is that correct?
Absolutely. The urologist is a critical piece of the care of these patients.
Post-treatment, are the monitoring techniques similar to post-surgery? For example, I know once you have prostate surgery, the urologist is hoping your PSA is going to be undetectable going forward. Is that the same in this procedure?
It is not the same because we are not eradicating the entirety of the prostate tissue. We normally leave some prostate left untreated, and those non-cancerous cells still produce PSA. So the PSA after a TULSA procedure will substantially decrease compared to the one before the procedure, but it will be a product of how much prostate we leave untreated, intentionally untreated. That PSA will be still a marker of treatment success as we correlate the number to how much prostate was left untreated. This is a variation of PSA that we call PSA density. So we normalize the number to the volume of prostate that was left untreated, and that will be monitored for years after the procedure. Now, back to your question, how a man after TULSA is followed to ensure that the treatment was successful. PSA is one element. MRIs are another important element. We will get MRIs to make sure that the area where the cancer has been completely ablated or destroyed and that there is no new cancer elsewhere. And if all these pieces are reassuring, then we do that again and again. And as our level of comfort and reassurance that that patient is cancer-free increases, these can be done with longer intervals between them. If something does not look right, so if the PSA is too high or if the MRI shows areas that look suspicious, then that man would be recommended a biopsy of that area focused on the region that looks concerning.
This is really fascinating to me. I could go on and on with questions, but I do want to ask this. Since you helped pioneer this at UT Southwestern, other major universities and medical institutions like Johns Hopkins, are they using this procedure?
There are many other centers that are starting their program. Because we started a while ago, we are the academic center with the highest number of treated patients. But right now there are more than 10 universities across the country that are either beginning to offer this or in the process of getting ready for delivering this treatment.
The innovator of what may become one of the benchmark treatments for prostate cancer in the future, Dr. Daniel Costa from UT Southwestern. Thank you for telling us about it. Steve?
Thanks, Thomas. Want to remind people on Medicaid, there will be a redetermination because the public health emergency is ending. Please complete all your required paperwork in a timely manner. And join us next week for the human side of healthcare.